This is a workshop of data science and AI to support healthy communities. So thank you very much, everyone, to be here. I'm Claudine Jurkovitz. I am the Director of Clinical Research in the Institute for Research on Equity and Community Health, or iREACH, at ChristianaCare. And I also lead the Biostatistic Epidemiology Research Design Core Board for the ACCEL Center for Translational Research, our Delaware CTR. And my co-organizer, David Chen, and I are leading this workshop, and I'm really happy to moderate this workshop. So this is what we are going to do. I'm going to show a few slides to frame the discussion of use of AI in healthcare. Then I have a slide to introduce our speakers. We have several rounds of questions. So the first round, we go over the advantage and opportunities for AI in health research and interventions, and then about the risk of bias and ways to address fairness. Then I'll have a second round of questions specific to each panelist expertise, but I will make sure to leave a lot of time for questions from the audience. So in a survey of 203 adults conducted in March 2021, so a little more than 4 years ago, people were asked the question of when an emergency room make a triage decision, such as which patient should be treated first, which system do you think should be used? And here, more than 90% of the people who participated in the survey said that they wanted a human medical professional. Only less than 10% said that they would want a computer algorithm to make this choice. However, when the same people were asked which system is more likely to make culturally biased decisions, human medical professionals were most likely to make a culturally biased decision versus the algorithm. In a very large survey of more than 11,000 adults, it was found that 60% of the people who participated in the survey felt that they were very or somewhat uncomfortable if their healthcare provider relied on AI to diagnose diseases and recommend treatments. This was a little higher in women. Can you see my? Oh yeah, good. Where 66% of the women felt uncomfortable versus 54% of the men. Higher among older people, 64% versus 56% in the younger generation. It was among people who had a postgraduate education, 47% of them felt comfortable compared to 36% of those who had less education. And interestingly, among those who have heard a lot about AI or who know about AI, 50% of them would feel comfortable for their healthcare provider to rely on AI to diagnose diseases and recommend treatments, versus only 28% among those who do not know much about AI. In the same survey, it was found that 75% of US adults thought that the health system moved too fast using this technology, even before fully understanding the risk for patients. And again, among those who know a lot about AI, 29% said that the health system moved too slowly, compared to 21% among those who do not know much about AI. However, it's important to note that even among those who know a lot about AI, 70% think that the health systems are moving too fast. So it seems that really we need to do better in communication about AI and how it would change the perception of AI. In the same survey, 38% of adults expect that AI in health and medicine would improve patient outcomes, and 33% expect that it would make a health outcome worse. So it's really not very many people who think that AI would improve outcomes. But we need to remember that this survey was conducted in 2022, so 3 years ago, and I think that things are moving extremely fast. So we need to keep this in mind and think about this when we think about this. In a survey conducted 1 year later of 600 adults, 50% of people who were asked how comfortable they would be if AI were used to assist doctors in making a diagnosis. 44% would feel comfortable if AI was used to recommend medications and treatment plans. More, 57% would feel comfortable if AI was used to read and interpret medical imaging, and 85% would feel comfortable if AI was used to schedule patients' appointments and follow-up. So people would feel very confident to use AI for administrative tasks, not so much for tasks assisting the doctors. And finally, in a 2023 survey of 2,039 respondents, astonishingly, 66% reported low trust in their healthcare system to use AI responsibly. 20% expected that AI will improve their relationship with their doctors, only 20%. And also only 31% had high expectations of benefit from AI in healthcare. And however, the respondents who had high trust in their providers were more likely to have higher expectations of benefit from AI. So in summary, regarding trust and comfortable, 66% of respondents report low trust. A majority of respondents were uncomfortable with AI diagnosing disease or recommending treatments, but we had a higher comfort with administrative users. Humans are preferred over algorithms for emergency triage decisions, but algorithms are perceived as less culturally biased than human professionals. And finally, only 31% believe AI will benefit patients, and 20% expect improved patient-provider relationship. So in summary, people are worried about AI. Can we, as scientists, communicate better about AI? What is the difference between AI and traditional data science approaches? And how can we instill trust about AI? What are the risks of bias and ways to address fairness? And these are all the things that we really hope to discuss with our extraordinary panel here. So I'm going to introduce our speaker, and if I may ask our speakers to come to the podium. Dr. Powers is Associate Professor at University of Delaware in the Department of Philosophy, and also in the Harker Interdisciplinary Science and Engineering Laboratory. Welcome, Dr. Powers. Dr. Beheshti is Associate Professor also at University of Delaware in the Computer and Information Science Department in the Epidemiology Program, and is also a research faculty at Nemours Children's Health. Dr. Dwikat is a Senior Data Scientist at ChristianaCare Health Services in the Community Health Programs Department. And Dr. Chen is a practicing physician, is internist at Christiana also. He's a medical director for Hospital Violence Intervention, EVOLVE, and is conducting research in iREACH, the Institute for Research on Equity and Community Health. So I'm really delighted that we are working with such a fabulous panel. So I guess I have a first question for Dr. Beheshti and Dr. Dwikat. What are the advantages and unique opportunities for AI in health research and interventions as compared to traditional data science approaches? Oh, microphone, yeah. Have several.
Thank you so much, Dr. Claudine, and that's actually it's a very great question. I will answer based on my perspective, based on my experience here at ChristianaCare, and Dr. Ahmad will have some maybe more about
The microphone is not working.
Can you hear me now? Thank you. So that's a great question. Thank you. I will answer based on my perspective and based on my own experience here at ChristianaCare. So traditional data science is good. It's the foundation for our analysis, for our AI, but it has some disadvantages, I would say. So AI is great. So using AI, we can discover like hidden patterns that traditional data science cannot like give us the answer. For example, patient comments. Here at ChristianaCare, we are dealing with more than 10,000 patient comments. They are black box. So nobody can tell us what are the sub-reasons about sleeping issues, for example, or cleanliness. In order to answer this question, you have to read the whole 10,000 comments. In AI, we are trying to use natural language processing in order to know the reasons behind them. So that's one reason. The second part of this question is real time. So AI can give you real time versus traditional data science. It's dedicated for retrospective. For example, our predictive model can tell us who will have, for example, bed sore in the future. So we are predicting the future in real time. In data science, traditional data science, it's retrospective. We go back and see what was done. And one last point is the scale personalization. Like we can predict like thousands of patients at the same time and giving each patient different prescription or different itemized plan based on the treatment. In traditional AI, that's like difficult. The last point is in AI, we can use multiple data, like we can use clinical data, we can use images, predicts at the same time. In traditional AI, it's like unique. You can merge all of these models into one project.
Hi everyone, great to be here. So, not sure I have much to add, but so you may have noticed I have a technical background, so just apologies if it becomes a little off the road. So, I don't think the question reminded myself, it was about traditional data science versus AI, right? So, I mean, personally, I think many people in the field also believe, and we all have started, there's a lot of hype and marketing, there's a lot of overlap, right? So a lot of people like me, if you were asking me what you do 6 years ago, I would tell you data science. Now if you ask me what I do, I would say AI. And for the most part, I don't do much different, honestly. So that's the caveat, right? But besides that, I think post 2020, there were a few major developments. Again, applied it becomes really technical, but so one of the things that again buzzword you may have heard is the term foundation models, right? So foundation models was before 2020, everyone was thinking about you have this is X, you have model X, you have this is Y, you have model Y, right? Now you're talking about something that claims, we can debate how much we have achieved that basically you have one big thing that can apply to any application you may have, including diagnosis, prognosis, different applications, right? So I can bring a lot of examples, but there was a recent paper a few weeks ago, folks from Europe, you may have guessed which data it could be a UK biobank. They basically claim that I think something can just say doesn't apply 1,000, 2,000 diseases that they claim they have very high performance, right? So this is one thing about foundation, and the reason that this is just we have it here post 2020 was just being able to go at scale, right? I think I'm just saying something in a different words, right? So, and one thing that a lot of us may have heard is just like a lot of these new models are basically the so-called next token generator, like, and it was like the fundamental thing of looking at every data. Again, you have heard it. If it is text, if it is image, if it is video, can you look at the thing as a sequence of things, right? And this is very powerful, right? So, because I think there's a cliche saying that the best way to learn something is to do it and generate it, and that was like what AI has achieved. Like, I know how to generate this data, which is very similar. Therefore, I claim, you can debate how much it is reliable. I understand the underlying distribution and like data itself, right? Again, image, video, signal, text, tabular data, anything could be. So.
Thank you. So I have another question for Dr. Paris and Dr. Chen. What are the risks of bias and ways to address fairness in health-associated AI? And how do you communicate limitations to interpretation and application community partners and clinicians? So mostly, in fact, the risk of bias and fairness and how to address fairness in health-associated AI.
Well, by starting with some clinical evidence. So half of what I do here is at the bedside, seeing patients here in the hospital, teaching residents, teaching students. And recently we had a very robust faculty discussion about how do we even interact with new learners who themselves are not yet masters of the information in terms of how they interact with AI systems, particularly the large language model systems like ChatGPT, with evidence being clinically oriented. And came across this one very interesting study where in one study, they looked at performance between residents and these trainees who are finished clinical school, but they're gaining their clinical experience before they become essentially accredited. And they found that the performance on their board examination was about equal to that of ChatGPT or the class curriculum, right? On Anderson's question. Now, here's the second study where they looked at a particular question, it was a pediatric question, and one of the answer choices was reassurance. Then this research team, all they did was change the reassurance to not the other answers, which were all true, which you and I, even not knowing anything about medicine, could say that they're probably the same result. The performance on these LLM models to this question, right, between these two options or versions of it, all the models increase their performance actually by at least 10%, become up to 30%. Even the ones with chain of thought and other orientations. And it opens this question, does it really understand it, right? And what is knowledge and its insight, you know, passing philosophy colleague, and the Chinese experiment and all these questions, what does it really know? And the really frightening, I'll use that word frightening thing is, then the practitioners using it do not understand, right? And then so the residents will sort of pop things in. They'll even use it on the side. I'll ask a question, and on the surface, their answer sounds exactly the same. And then I'll ask probing questions, and then trying to understand what's underneath there. And not to say that we scare away people from using the AI technology, but that risk there of bias in part comes to not being able to articulate the chain of reasoning and why they arrive at a certain location. Even before AI came about, I would actually, every time I rotate with students and residents at the conclusion, I will ask them, I say, in your 1 or 2 years working with us on our team, where did you observe bias? Right, on our team, and how could we have done better with it? And here are different examples of bias. There's statistical bias, there's anchoring bias, or some other officers diagnosed, but it was something different. Was there racial bias, which is sort of economic bias, towards mental health, or substance disorder. And every time I ask that question, every person rotates. And it's very illuminating to see that thinking you're like, oh, you know what, I didn't recognize there were all these layers of the human level. We saw from the slides we brought up earlier, how people recognize how people are biased. Now when you have an LLM that speaks of things with high confidence, right, in tone and in language, but it's a black box where even with a chain of thought algorithm that says, you know, what are the linkages in between, how much do you really understand what's going on? How teachable is it? How well can you change and adjust for those things? And at what point does there become an inversion in what's the population, the community trust, and what they view as trustworthy within ChatGPT versus us, right? It's the new Dr. Google. And it's very interesting to look at those questions. So I'll just leave those out there, some vignettes and examples, and pass them.
Very much, and it's great to be with you here. Just anecdotally, the inventor of the Chinese room argument passed away earlier this month. His name was John Searle, and when I was teaching out in Silicon Valley at Santa Clara University, I overlapped with him, and unfortunately, I didn't know that I would later have all of these interests. This was in the previous millennium. I didn't know that I would have all of these interests in AI, and I could ask him all these questions. So I failed to do so. So I teach a course, a graduate course called Ethics in Data Science and AI, and two of the main modules in that course concern 1 week bias and the next week fairness. And if you look at the literature on bias and fairness, what you'll see is there's a great deal of overlap, and maybe in fact we can't distinguish the two. Bias is systematic error in a system typically created by the training data on which the system was created, or in some cases, bias introduced by using the wrong algorithm or not tuning the algorithm, right? And fairness is, I tend to think of it as including bias. It's a kind of bias that we don't like, right? That we find objectionable for one reason, typically because it produces an outcome for a particular group that we think is unfair for that group, right? So this is well known in medical AI. If you have training data, which are predominantly from white men, you will not have a training set that is representative of the population on which the model will later be used. Is that something that tells us we ought to throw out the model entirely? No, but we ought to correct it in ways so that that bias is no longer somehow pernicious, if all possible. So one of the ways of getting rid of bias is to look very seriously at the data on which these models were trained. Now, in the case of large language models, as we all know, they were trained, these foundation models were trained on everything that OpenAI could get their hands on. A lot of it was Wikidata, but they were trained on documents of science fiction in some cases. So the prediction, what's the next best token, includes data from science fiction. So it shouldn't be surprising that we have hallucinations and a variety of biases that show up. If we look at machine learning per se, and we think about training data for a machine learning model, you have in principle a great deal more control because you, in all likelihood, have a much smaller data set and you know the outcomes for which you're training. Doesn't mean that you get rid of the possibility of bias, but the amount of data is certainly much smaller than these foundation large language models. So when I teach this course, I have students look at some, you might say, technical or statistical definitions of bias slash fairness. And one of the real indicators are what are known as type 1 and type 2 errors, false positives and false negatives. And so you have a formula, and there's no one formula that's going to do the trick, but you have formula which can give you a measure of the type 1 and type 2 errors of a particular population, of married women from San Jose, California, if you want to become that precise, or of left-handed people, or of men, women, or any group that you want to cut up. So you could have bias in almost any group that you choose. The historical bias that we're worried about right now is the preponderance of medical data that depended on prior access, and that was usually money or good health insurance. So I'm a little bit hopeful or optimistic that we could get rid of bias in healthcare AI, but it's going to take a lot of work. It's going to be rolling up your sleeves and looking at the data sets and trying to understand the nuances of training.
So you think that we are really just at the beginning of trying to get rid of bias?
Well,
We don't have enough data yet.
I think these are early days. Yeah. And Ramada and I and Dr. Chen, we've been working on a grant on knowledge graphs, which typically do not have the same, or at least the same pernicious worries about bias that a large language model might. So, obviously ChatGPT is the latest shiny thing. It's accessible to all. You don't have to be a computer scientist to know how to use it. But, talk to me next year and I think there's a good chance that we'll be talking about something else. Or at least maybe ChatGPT or GPT-6 or something else that has new problems that we have not yet enlisted.
Thank you. I think I'm going to open, considering the time, to open the floor to discussion at this point, if you have any questions. Dr. Bacon.
One of your slides was poignant in commenting that 66% of Americans or humans do not trust a healthcare system to use AI in a sorry. So you're
Oh, there is another one. Okay, good.
Yeah, turn it back on.
there. So one of your slides was poignant in commenting that 66% of humans did not trust healthcare systems to use AI responsibly. Would you, for you define what's irresponsible use, unethical use, or even illegal use that a healthcare system could then, even without knowing it, utilize AI inappropriately? I mean, where's the other side of that? Don't all talk at once.
Who wants to take first back? Again, just to start, like. Okay. Yeah, well, I guess just to repeat the question was like, what are example irresponsible
uses of AI in the healthcare arena.
Well, one thing that, like, I mean, for a long time, medical research has been very familiar with like patient consent, right? And this becomes so vague and blurry when it comes to AI, right? So this is just probably the number one thing I would put out there. Like, I mean, where is really the border to draw? Like, if it is anonymized, do you need to basically go to every individual and ask them, do I have your consent to train this model, which is going to impact like 200 million in the world? And well, you may argue that no, but like we also have a lot of like development every day that like everything identified seems to be relative. Like in 2025, that may mean de-identified. In 2023, it may not be, right? So like where you should really just kind of be responsible and have the patient consent, right? So just put it out there. And if the rest of the panel want to add other things.
I can just have a comment here. Like this survey was in 2022. Like if I need to ask this question, like the audience who replied, did they know what does AI mean? That's the question that we need to ask ourselves. I did my PhD, I would say AI, it takes me 5 years honestly to understand the math behind AI. So AI is not ChatGPT. So when you are somebody, you trust AI, maybe the question will be biased. But here, for example, in ChristianaCare, we are doing tons of AI, but our patient doesn't know what we are doing. So that's the difference. Like maybe it's misunderstanding or what exactly AI.
So I have a much more dour perspective on this, and from both the communities, because what's the theme of this morning, right? And all of the talks about trust. And what does that mean to trust, or mistrust, or distrust institutions versus whatever? And even studying human behavior and their interface with medical systems, this is part of what I look at as sort of violent injury, policing systems, things like that. That trust is very, very, very fragile. And generally speaking, people are much more likely to trust a human being they know than a system in general. And in part because they feel like they can understand the intent behind an individual, right? Based on how they read the person, how the person is communicating with them. When you talk about AI, now it's suddenly distance, but isn't distance in the same way a machine is distant. With ChatGPT having this very personal role near to it, does that ironically have more trust actually in it as compared to other human beings? And I say this because when you talk about the trust system, we must recognize that the systems themselves perpetuate violence and bias and things sometimes with intent. Right? And so to put an example out there, when a health insurer uses an algorithm, AI-based or even traditional machine learning-based, with which to go through many, many records and lean towards denial of coverage. That's bias, is it not? Is that something that violates the trust that we have? It sure can. And the degree to which that intent is there, I think, comes to this question, fairness, right? Of what do we mean when we say bias, right? It got a result that perhaps the system was looking for, and so therefore it filled its intent. But then to the person who's being covered or not covered in a situation, they may have very strong feelings about that. And then once that trust is broken, it's not usually regained. What happens then when multiple systems are using collaboration? Right? What happens when individuals identify with the system or identify against it? Right? And so I think it's very complex when we talk about what does trust mean. And I think that's the foundation of that question. What do you trust and why do you trust it? And I think a large part of it is how can you interpret the intent of the person as well as the capability of that entity, whether it be one organization, individual being living or not.
You haven't come to law first. Those are all deep philosophical questions. I want to focus just a little bit on responsibility because it's an area in philosophy in which I work. So I think the one answer to your difficult question is to understand better what we mean by shared responsibility. So now I'm going to say something about medical practice that is completely outside of my knowledge base. And basically, I understand medicine by watching television shows and what my sister told me. My sister, by the way, is going, I think, on her 50th year of being a nurse. She just wants, she retired and now she nurses for fun. So think about the structures and the sort of fault ways that the healthcare system has for introducing new practitioners into the field, whether it's a resident or a newly minted nurse. You know, it's, as far as I know it, the TV shows are not lying to me. It's never the case that you're there in the emergency room and the new person shows up and you say, well, it's your show now, I'm gonna go get coffee. Right? So there's always a great deal of oversight and care and mentoring, and there's also a good bit of skepticism initially, right? So you're looking over somebody's shoulder and you're making sure that they're doing things the right way. So one of the other areas that I work on is the concept of agency. And in computer science, they've been comfortable talking about computer agents for a long time. In philosophy, less so. I think philosophers just ought to give up on their apprehensions. These things are agents in a significant sense, but that doesn't mean that we now absolve, we practitioners, and I'm talking about you actually, that you absolve yourself of all responsibility and say, well, I've heard that this AI diagnostic tool is pretty good. I'm just going to let it run and I'm going to go have coffee. Right. So there has to be a way in which medical professionals introduce shared responsibility to this new kind of agent, or to be more precise, introduce the new kind of agent to their practice, to the structure of their practice, to the rules, to the folkways, to mentoring. And you got to be skeptical, right? You got to keep one eye over the shoulder of this thing, metaphorically speaking. I think that's the best hope for good outcomes.
I think, David, you had some interesting examples also of the skepticism, right, that you have and when teaching to residents.
Yes, so I have incorporated some examples here, which I'm going to do and de-identify the spot on multiple levels. So here's a couple of examples to this event. Trainees and how they just one example is a resident a year ago first talking to LMA and says, oh, something wrong with it. I asked a difficult question, but it's very clear you can see it pretty easily. It provides you with answers. Oh, yes. Another example is I have a patient. They had a diagnosis. We were treating the patient for the diagnosis. There was a medication which had a rare but potential side effect that could be fatal. And I said, as the primary attendant, I do not feel confident that this should be medication because of this. And then the specialists kind of disagree. They said, well, I think it's safe not to use, which was fair, right? And then the resident said, well, I put this into this LLM, right? The AI from evidence, and it says that this is not something that's wrong. So I sent back a screenshot of Lexicon, which is the drug monograph, right? The actual manufacturer saying this is absolutely this thing. We had an interesting conversation about what afterwards, right? And then third example is a resident comes in and says, hey, we could be doing this treatment for this patient with substance disorder. But I don't see this in when I put it into the LLM as an approach for it. And I'm not really sure how to perceive that. And I said, well, part of it is that what we're experiencing, particularly in relation to kind of new street drug substances that are out there for which there hasn't yet been developed the body of evidence to how to best approach it, saying we don't know. That's what's not in the LLM, the data sets, the update. And so there are these different layers to it. And I think too, what Dr. Powers was saying, when we talk about skill, right, and that kind of oversight, it sounds great. And in reality, let me ask any clinical practitioners in the room, let me ask you if you feel as confident in your physical diagnosis skills as a clinician from 2 generations ago, right, in terms of using statistical observation, right? And the reason is because imaging technology has gotten so good in the interim that what has happened is you see clinicians begin to de-skill actually to lose that ability to be able to do picture repetition or never skill in the use. Right? And that's, I think, where this question of do we even have the capacity to generate that oversight? How many down
Michelle. Hold on. Let's have a microphone.
So it's not a matter of whether AI is coming, AI is here. And so listening to you talk, Dr. Chen, what do we do with this next generation? We have, high school students going to college who will eventually be our future physicians. And if this is a path, how do you make sure that they do critically think, that they do learn the skills because AI is here?
I think it's a question for all of you, actually.
Answer on the board actually, that is education, right? I think that seems to be closer to the silver bullet thing, it is closer, but like it's just really all about education, right? So from the population level, like many people argue from the elementary school children, like people really real life. Even I can probably talk about this forever, but like one of the key concerns here is automation bias. I think it was mentioned here as well. So there's a lot of analysis people are talking about like aviation industry. So as we know, like when you are taking flights, for a good portion of it, it's not a person, human doing it. It's just like automated pilot, right? So and apparently, I didn't actually know, like somebody maybe correct me if I'm wrong. Apparently, there are some rules that require pilots that after using this system for so many miles, they're required to take the control manually such that they don't lose this muscle memory. And many people argue that it has to be applied to the medical community as well. If you are a surgeon, if you are using robotic surgery this many times, 101 must be manual, right? So if you are using AI this many times, this one such that but I mean, I'm just going off rail, but like, I think the main thing we can do is just education, like people are realizing what this is, what it is not, right? So at the level, I mean, you don't need to know all the, like the math behind it, like the basics of it, like it should probably sometimes even like, I would say distracting, you know, all the details, like, okay, I'm fine, like, and the application, like, maybe figure out what we need.
I'm going to give a biased instance. We both work for the University of Delaware. It won't be surprising if I, put in a pitch for education. But let me compare the situation of faculty, higher education faculty. So, ChatGPT was dropped on us, just like on the rest of the world, and I actually think it was quite. If I could think about those people who make the decision, people who are running OpenAI and other corporations, I think it was quite irresponsible. So as far as I know, they did not consult any higher education people before they said, oh, look, you know what? All of your students can have access to this. So I sit on, I'm losing now count of the number of committees at the University of Delaware where we're worried about radically restructuring higher education because of large language models. And that means changing all of our evaluation devices, no longer requiring long papers because it just, just something that's generated by chat. You can be a clever prompt engineer, but it's no sign that you actually learned anything. So we're, after ChatGPT 3.5 or 3 was dropped on us, we started meeting and trying to figure out what does this mean for higher education. And every university worth its salt is doing this. And if they're not doing this, they're going to be out of business really soon. I suspect that in terms of medical education and training, you're going to have to do some of the same thing, right? I agree with you, it's here to stay, but what that does for education is an ongoing problem that everybody has to roll up there. And by the way, I don't think that you can rely on ChatGPT to figure out the educational question.
Good afternoon. I want to thank the Buddhist medicine people for stealing me right back here. Thank you to the panel. Dovetail question. I'm thinking about digital literacy and tech access is just another social determinant of health. And I'm curious what we're doing at Christiana, at Nemours, at UD, etc., to help educate patients, community members, and providers too, how best to use these products and how to make sure that we're not re-exacerbating existing disparities. We talked really about today. What are we doing on the education front and for patients and providers? Thanks.
Yeah, that's a great question. And I think ChristianaCare started their strategy, AI strategy. So nowadays we are moving to EPIC. Last month we have like another. Can you hear me now?
No.
Also, we are integrating with another vendor called Something. You heard about it. So now I would say AI will be involved in our work in many fields. And as far as I know, large language models will be used soon. Based on ChristianaCare policy, we were not allowed to use large language model because of patients' privacy. But from like the days on, we will start to like using those. Your question is very good, but I would say we are in the very early beginning stages because there's no like clear picture where we are going. Because healthcare, we have so many constraints, not like university, because you are dealing with patients, have data. So if you need to compare what our level in AI compared with banking, with Chase, we are very slow in that. But nowadays, ChristianaCare start adopting AI strategies for users. Like this will be using very wide screening.
I think, if I understand the question, the focus is on this, the silver that we understand the disparities that already exist, the risk of technology as every age of worsening certain disparities, and often those with least access before still being least accessible later. Am I echoing? I noticed some very interesting things, particularly with, I think, LLMs and AI that is that different. I kind of wrote about Dr. Google, right? Where here's the hundreds of pages that I've been reading through. And I remember living through that and going, okay, that's great, actually. I'm great because of engagement. The patient wanting to know more about the condition, how can I help you be more empowered and equipped to do basic algorithms. Then there was social media. I heard this on Facebook. Less about the content and the accuracy of it, so much as the face validity of it being from a trusted messenger. And that actually carried more, again, coming back to the trust issue. And that totally wipes out any of the content. And so I would argue about really face about what the reality and the importance of that data is or what the data says. But if there's no trust and the message that they're hearing comes from a credible messenger that is more credible in their mind, it doesn't matter what I say, unless I have already worked to build trust. Ironically, when systems take over at a certain level of efficiency, they want to substitute the system that has that credible messenger, and that's not how it works, especially in healthcare. Again, it's the individual human being that we are, I think, wired to want to trust. So now AI comes in with LLMs as kind of an interesting third space. And what I found is actually those who previously had less access pay for $20 a month for ChatGPT, and the quality, the nature of the quality of information into the content, as well as its delivery in a way that actually feels trustable, more so than other traditional messages that were not as trustworthy, has changed the game. And I still have made my mind up as what I like, but I engaged it. Right? And just to say that, I think it's very interesting that kind of conversion. Now, I guarantee that they're going to start raising the prices in the rate, and then we will see the wide data. But I think we're a really interesting window here where I'm not sure that the disparity, I see something around the road. I see how much sophisticated analyses, questions, the pressure from community organizations, because if you augment it by the AI that they have access to now, and so it helps some of it, I think, on some playing field. But I think needing expert supervision to really have deep knowledge of the content, again, will still be necessary, perhaps even more critical now when we just think of sub-readers.
Any other comments? Oh, I think that would be the last question, unfortunately.
I'll probably agree. When I'm sitting here thinking like a patient, and if I became a patient after sitting in on this workshop, and the doctor came in and said, we are prescribing, this medicine or this medication for you. I'm going to have a lot of questions, and a lot of data. And I think one of the things that can neutralize the concern that I would have would be a great relationship between patient and doctor. So that the doctor would give you the time, to talk about, what's going on with you, why you take this medication or this medication is good for you. And these are the kinds of things, that could happen. I think the other thing is old time medicine. I mean, it may not be old time, but taking the medical history, it's so important. But I think the new era that we're in terms of AI intelligence. I mean, I was a patient not too long ago here with a serious illness. Doctors would come and say, we want you to take this, we want you to take that. But what about other illnesses or just my personal history? How much have you taken that into account? And the doctors who would talk with me were the doctors I trusted. To the extent of doing the prescription on the advice that they gave. And if I'm talking about old time people skills, that's also important, in treatment.
I think that instilling trust is really not an all-time skill. I mean, it is. I think this is really what we need to strive to. And probably that will be the way of for people to trust AI if we as scientists and physicians make sure that people trust us first. So the last word, what do you hope, each of you, what do you hope for the next few years, the future? What do you hope in relation to AI?
That's a big question. If I need to answer in healthcare, I will give my answer in healthcare to have much bigger adaptation for AI. But as I said, we are very slow in adaptation compared with other tech companies. I used to use AI in 2016 in telecom industry, not today. You are saying 9 years ago. But in terms of healthcare, I hope the adaptation from physicians themselves, from caregiver, to start using AI. And this needs a lot of work. It's training, it's trust, needs a lot of work. So that's my hope for the healthcare.
I'll be very brief because it involves my own research. I actually hope that we'll figure out how to code ethics into AI. And this is something that I've been working on. I started working on it in a sense as a graduate student. I wrote a chapter in my dissertation, which I thought was going to be a throwaway chapter. And I later read the paper at an AI conference, and it caused a 180-degree turn in my career. But it's not an easy question. There are a variety of research programs to, in effect, place ethical guardrails about privacy and consent, about bias and fairness into these AIs, or at least to screen them for outcomes that are, we all know, either hallucinations or downright dangerous. So I hope we'll figure out how to do that. It's kind of, in some sense, my life's work. It's not easy because value language doesn't translate easily into something that's computable. But that's what I'm looking forward to.
My hope is that, and don't get me wrong, so I was on the research side. I work a lot on the side effects of AI in healthcare, social bias, and I know firsthand how the whole system can go wrong and make things worse than they could be. But my hope personally is that, in the near future, the healthcare community, all of us together, start more thinking about really the benefits more than all the concerns aside. And this is the theme, rightly, we have to talk about them. But a lot of things that at the same time you have to think, how many lives this AI is going to save, right? So how many people are going to be able to see doctor that they won't see without AI, right? So, and these are also very critical. And I mean, again, it may sound like I have a conflict of interest because I'm a tech person, like a tech background, that I'm pushing for things, but I'm just paraphrasing that, like, one of the famous physicians, he was from Harvard Medical School, and he was saying that, like, if healthcare community, all of us don't go this route, I mean, some other big tech communities are going to overtake it the other way, right? So it's best to be in the hand of people who understand and care about the patient. I think we don't have any shortage of those examples in the business work recently happening. Like, think about transportation, think about like a lot of logistics, etc. So this is just one hope that we have.
I hope it doesn't take over before I can retire. I don't know. In all seriousness, that was one more hopeful. I think that I've been thinking about it and to try and be a hopeful. I think building more AI literacy, right? We talk about health literacy and the basic sort of thing. I think as clinicians on the clinical side, we need to really, we have very defined, like the education system is struggling to catch up. We are even more on the back foot, and it's a lot of very bright, a lot of brilliant colleagues here. But how to do that better?
Right. Well, thank you so much. I think we are a few minutes late. This was a really wonderful, very inspiring discussion, very inspiring panel. Thank you so much.